and sickle beta thal 0. In that case, you inherit one of the sickle cell genes and a beta thalassemia gene, where they'll make no normal hemoglobin A, and they have moderate to severe anemia and hemoglobin 7 to 9. So hemoglobin excess and hemoglobin excess disease and sickle beta thal 0 are very similar to each other. The only big difference is the MCV. They're more microcytic of blood smear. In general, sickle cell affects about 90 to 100,000 Americans, 1 out of 365 African-American births, about 1 out of 16,000 Hispanic American births, and in West Africa, notably, for every 100 West African births, 2 have sickle cell disease, more complicated. In terms of sickle cell severity, it's affected by fetal hemoglobin levels, co-inheritance of another thalassemia gene called alpha thalassemia trait. So if you have alpha thalassemia trait, it tends to make the sickle cell milder. And also inheriting milder forms of sickle cell disease, so SC disease or sickle beta thal plus disease. So I'll just briefly go over this general schematic diagram of the body, just telling you how sickle cell disease affects so many organs through time. So in the first year of life, it's been shown that sickle cell disease actually can affect the kidneys that early. It affects organs throughout the body. I'll start from the head. In the brain, approximately 10% of sickle cell patients will have strokes. That's overt strokes, not having the ability to walk or talk, that lasts greater than 24 hours. And then there are these silent strokes or silent infarcts. That happens to about 30% of patients. That's a little more ominous because those patients, they don't have a loss of neurologic function. They just have sometimes associated neurocognitive defects. So patients who have difficulty with school, learning disabilities, anything like that, as it relates to academics in school, that might be a reflection of silent infarcts. So it's about 1/3 of patients. Lungs, as they get older into adulthood, pulmonary hypertension is a leading cause of death in adults with sickle cell disease. Acute chest syndrome and chronic lung disease, but acute chest syndrome is probably the leading cause of death in children and adults with sickle cell disease. I'll talk about that later. Over time, you can get chronic lung disease from repeated acute chest syndromes, and with concurrent asthma can cause lung problems and oxygenation problems. Spleen, as everyone knows, the spleen is very vital in removing encapsulated organisms, most notably pneumococcal bacteremia. So strep, pneumococcal bacteremia, we don't see it as much anymore, but we do recommend penicillin to kids under the age of 5 to prevent infections. Also, vaccinations with Prevnar 13 and pneumococcal vaccine 23, in addition to the meningitis vaccines. Priapism in males, about 50% of patients will have priapism by age 20. This is blockage of blood flow in the penis, can cause painful erections. It even can start as early as 2 to 3 years of age. It's very embarrassing for school-aged children, males. In those cases, you have to treat them usually with fluids, pain management. For severe cases, you actually have to go into the penis to do evacuation with urology in the emergency room. Kidneys, about 20% of patients will have sickle cell nephropathy, where that is measured by spilling protein in the urine. So we measure that by testing for urine microalbumin and urine protein to creatinine ratio. These two studies are done as part of their routine maintenance. Gallbladder, same thing. At least 50% of patients will have gallstones, and this is because sickle cells have a very rapid turnover. When you break down hemoglobin, it makes bilirubin, and you get bilirubin gallstones. We usually don't recommend removal of the gallstones immediately, only if it's causing symptoms such as after eating fatty foods, having abdominal pain after eating food, or a gallstone is being lodged into what's called a common bile duct, causing swelling of the gallbladder. The heart, usually they have a large heart just in general. Thickened heart, at least 80% of patients, because they're chronically anemic and the muscle in the heart is thicker. In very rare cases, you can get cardiomyopathy. You see that in adults and in children. And then for eyes, retinopathy, about 20% of patients will have some type of retinopathy. You see this more common in SC disease patients. You can see this as early as 10 years of age. Health maintenance visits, usually here at Children's National Medical Center, downtown campus. We discuss between 2 and 3 years of age, education and parental counseling. We have group education sessions. We do labs on probably 2 to 3 times a year, just to make sure, find out where their hemoglobin is going to kind of level off. We do hemoglobin electrophoresis, which tells you what type of sickle cell you have. And we sometimes do that to differentiate the types of sickle cell. But the other reason is to see how high level you have of fetal hemoglobin. Fetal hemoglobin predicts milder disease if it's higher. So some patients we can help counsel based on the level of fetal hemoglobin. If we want to put them on hydroxyurea, which we'll talk about, to increase fetal hemoglobin or not. Genetic counseling is always given to families in the beginning and during for having future children, for example, discussing sickle cell trait and its implications in the other children. Splenic palpation is very important because you can monitor for splenic sequestration, which we'll talk about. Penicillin prophylaxis, we start penicillin in children, newborns, all the way up to age 5 when we stop it, unless we take the spleen out. The spleen is completely removed because of splenic sequestration. Surgically, we move forward and continue the penicillin beyond age 5, because sickle cell patients have 400 times risk of developing pneumococcal sepsis than the general population. Management of pain crisis. How do we treat pain crisis? Discuss that. And then, of course, immunizations, which we'll get into, pneumovax and meningococcal vaccine, and Prevnar 13. Social services and worker support. A lot of patients, because of, in some cases, the burden that the family has, depending on the severity of sickle cell disease, repeatedly come into the emergency room. Over time, can take a toll on the families. Most families do very well, but we do provide additional support for families in terms of financial needs, psychological needs. We have a psychologist here. Also, it becomes an issue in terms of mental health screening and depression as associated with sickle cell disease, generally in older populations. As we talked about, this is more for older patients. We actually have families not only seen here at the Sheikh Zayed campus here at DC Children's, but also at Children's National Medical Center, but also Laurel Lakes and Shady Grove. The only thing I'll mention is in the older patients here, we do ophthalmology referral at 10 years, ophthalmology screening at 10 years of age for retinopathy, transcranial Doppler ultrasound, child psychology, pain clinic. We have a comprehensive. We also have a comprehensive pain clinic and our chronic pain center where we consult with our anesthesiology pain physicians for patients who are on long-term, who's having chronic pain, and the multimodal approach for that. Bone marrow transplant, which we'll talk about, is also offered, and of course, as we mentioned earlier, hydroxyurea monitoring. Just mention that patients on hydroxyurea needs to get their labs monitored on a sometimes monthly basis when they just started hydroxyurea. But if they're on hydroxyurea at a good dose, you don't need to monitor labs until you don't have to monitor labs until every 3 months or so once they're in a good dose, which we'll talk about later. One thing I wanted to mention, because we have general pediatricians in line, is growth and development. Monitoring growth is essential in sickle cell patients. About 10 to 15% can be underweight, BMI less than 15. Supplemental nutrition may be needed in some cases, even referrals to nutritionists. Height and weight can be delayed up to 2 years compared to gender and age-matched peers. Ultimately, sickle cell patients catch up to their peers in growth and development by the end of their teenage years. It's almost like constitutional growth delay. A very small percentage still have stunted puberty and growth. So in that case, we do refer them to our endocrinology colleagues, also consult with their nutritionist in addition to that. Immunizations, I just want to highlight this because this is very important. I mentioned it earlier. I just want to highlight the fact that sickle cell patients are risk for invasive pneumococcal vaccinations. So you have two schedules. You have PCV13, Prevnar 13, which is given in the primary series in the first year of life, first 5 years of life, and then you got catch-up PCV13, which we recommend in adolescents and adult patients, and then we have pneumococcal vaccine. Meningococcal vaccine, Menatra and Menveo, is also something that's changed since Menveo is now part of the primary series of infants and young children. We generally will go with Menveo at this point, but in our catch-up in our teenagers who have not gotten Menveo, we go with Menatra, especially entering graduation, especially entering college. Regardless of what they do post-high school, we recommend Menatra. And then influenza A vaccine yearly. The other point I want to mention is patients who have their spleens removed surgically, we vaccinate them before they have their spleens removed to make sure that's optimally done. Also screening, and just to highlight transcranial Doppler screening, this has changed the actual incidence of stroke that we see in sickle cell disease. We don't have a lot of stroke that we see now because of this. This screening is done at sickle cell centers here at this Sheikh Zayed campus at Children's National Medical Center. Our ultrasonographers screen the severe types of sickle cell disease patients, SS and S beta 0, annually from 2 years of age up to 16 years of age based on the STOP study. The STOP study is a study that they looked at, compared sickle cell patients on chronic blood transfusions versus no treatment with TCD velocity greater than 200 centimeters per second. They compared the observation arm versus the transfusion arm. 10% of the patients develop a stroke per year, 9 strokes in the observation arm versus just 1 stroke in the chronic blood transfusion arm. So therefore, we recommend starting blood transfusions in all patients who had elevated TCD velocities. We also do MRIs of their brains and MRAs of their brains to see if they have stenosis of their vessels. And what they also did was after this, so we then went from, this was back in the late 90s to the 2010s. Now we have a new study that came out called the Twitch study, and now they compare hydroxyurea to chronic blood transfusions for patients with elevated TCD velocities. Remember, this is for primary stroke prevention. And what ended up happening was that they found that this hydroxyurea at the maximal tolerated dose was not inferior to chronic blood transfusions, basically saying that you can use hydroxyurea instead of chronic blood transfusions for primary prevention of stroke for patients who have abnormal TCD velocities, with only one caveat. If they have elevated TCD velocities and their vessels in their brain based on MRAs of their brain are not narrow, you can use hydroxyurea. But if they have vasculopathy in their brain that's severe, meaning that the vessels in their brain are narrow in more than one vessel and it's severe, hydroxyurea seems not to work in those cases. In those cases, we keep them on blood transfusions. We know about vaso-occlusive crisis. It's the most common manifestation precipitated by multiple things: temperature changes, stress, infection, dehydration, spine, pelvis, long, flat bones are commonly involved. We use hydration and pain meds for this. So to give an example, a case of dactylitis, 1 year of age. A 1-year-old patient with sickle cell disease with irritability for the past 2 days. This is a common look for dactylitis, so this is one of the things in terms of warning signs, kind of jumping in out a little bit. You can see the swollen digits, phalanges between the fingers. They're usually, some kids have kind of pudgy hands, but you see a change and they don't want to move their hands as an example of that. 50% of patients less than 2 years of age present as the first symptom. Tylenol, Motrin. Sometimes you have to do narcotics in very, very few cases if we need to do that. Tylenol with hydrocodone, oxycodone, any of these opioids are usually rarely needed, but in severe cases may need IV morphine and inpatient. So if home management fails the family, patient needs to come to ER and get possibly admitted. And sometimes differential in this kid would be like fracture, infection, sprained finger. But the most important thing is recognizing it. I want to talk about hydroxyurea a little bit because this is part of the treatments. And as we talk about pain a little bit, I want to just mention this is because this is FDA approved in adults, but is recommended from the NHLBI guidelines, NIH guidelines for sickle cell disease published in 2014 in young children, anywhere from a year and older. It increases fetal hemoglobin. It decreases white count. It decreases reticulocyte. It decreases inflammation, decreases adhesiveness. So we now know that sickle cell disease not only causes pain crisis from the standpoint it decreases pain crisis from the standpoint of reducing the amount of sickle cells and increases fetal hemoglobin, but also decreases inflammation. It's almost like putting water on a fire. Inflammation is a fire. It really cools it down. We're finding out more and more research is sickle cell disease, the way sickle cells promote crisis or go into a crisis, it involves other cells, such as white blood cells in the vessels, within the red blood cells, within the vessels. It involves a vessel lining, which we'll talk about in a minute. In the adult study, hydroxyurea was shown to reduce the frequency of pain crisis and hospitalization, acute chest syndrome by 50%. The baby hug study, which I'll mention, looked at babies from 9 months to 18 months, and it's shown to be safe and effective in decreasing pain crisis and acute chest syndrome. Adverse effects, myelosuppression, which is low white count, low platelets, and sometimes low hemoglobin. Long-term effects are not known in children, but in adults has not been shown to increase the risk of cancer, which sometimes we have the misinformation of that. So we know in adults it does not increase the risk of cancer. In children, we just don't know yet at this time. Visits are done every 3 months and more frequently if any dose change. Oops, wrong direction, sorry about that. So for the NHLBI guidelines, this is from the NIH. These are actual from the guidelines and strong recommendation. In adults with sickle cell disease, just to mention, sickle cell anemia, 3 or more episodes of moderate to severe pain crisis in the past 12 months should be treated with hydroxyurea. Also, acute chest syndrome should be treated with hydroxyurea for current episodes. In infants 9 months and older, children and adolescents with sickle cell anemia offer treatment with hydroxyurea regardless of sickle cell severity to reduce sickle cell-related complications. Strong recommendation, high-quality evidence for ages 9 to 14. I put this here because it's from the NIH. It's not FDA approved, but it is widely used. At least 50% of our general population at Children's National Medical Center is given hydroxyurea. We actually have an educational clinic that Dr. Nichols does, educate families who are hesitant in using hydroxyurea. That have education class Fridays with Dr. part of our sickle cell program. And I just want to show you briefly this one slide from the baby hug study, just showing the effectiveness of hydroxyurea. Acute chest syndrome 8 to 27, pain 372 to 177, dactylitis 123 to 24. I just want to show this is the evidence showing it works pretty effectively in patients with sickle cell disease. Case 2, just to mention, Reynolds, 15-month-old male with rhinorrhea, fever. This is just a hypothetical name here. This is not a name. So this is a patient who has prior hospitalizations for sepsis, dactylitis. And one of the things I want to just mention is this patient has a history of sepsis. That should be a red flag in any patients with sickle cell disease with a history of sepsis. And also I want to mention immunizations and also penicillin. Are they taking the penicillin every day? Are they doing immunizations every day? That's something you want to look into that. So it is recommended. 400 times risk of infections, most common cause of death under the age of 5, and it's due to splenic dysfunction. It's not working well. The penicillin PROP study resulted in an 84% reduction in infection in children with BID twice-a-day penicillin prophylaxis. You use 125 milligrams twice a day in children less than 3, and then 150 milligrams penicillin in patients older than 3. I'll just keep going here. I think we went over this. Penicillin prophylaxis, patients who have a history of splenectomy, we go beyond age 5 to 6 years of age, continue the penicillin. We also continue in patients who have documented pneumococcal sepsis or bacteremia. So patients who have a previous sepsis with strep pneumococcus or splenectomy, full splenectomy, we continue them. Outside of those two indications, we stop the penicillin. Okay. All right, so we talked about that. Right. So now, the only thing I'll just mention in patients who we still do blood counts and also sources of infection, we got to think about cough, upper respiratory tract infections, chest x-ray, pulse ox, high fevers, headache, and think about meningitis in those cases. We rarely see that because of the vaccinations, but I just wanted to mention that as a possibility. Considering no source of infection, we highly consider chest x-ray, urine analysis, and culture. It doesn't have to be catheter associated, it can be just a clean cache. Acute, also consider acute pain crisis, antibiotic coverage for strep pneumococcus. And these are the cases we do give. Now I will say these are the two non-toxoplasmosis, toxoplasmosis. Sometimes we have to add vancomycin for resistant strep pneumococcus. What we've now been using more recently instead of clindamycin is levofloxacin. So that's been also used for fever management in sickle cell disease patients. So the clindamycin is sometimes used for levofloxacin, sometimes used instead of clindamycin for cephalosporin allergic patients. So vaso-occlusive crisis, I just want to mention recent changes in weather, warm to cold, walking in the cold, viral-like symptoms the past 2 days. I just want to mention this because when I think about warning signs for vaso-occlusive crisis, we just think it's pain. But the first thing you notice, there are weather changes. Patients will also say, oh, I was walking, it's raining outside, I got caught in the rain, viral-like illness. The other thing, is let's say they had gym that day in their school, and they were running and it was cold outside. Did not dress well. Those are kind of the warning signs for triggers of a pain crisis. Okay, and I'll just move past that. Vaso-occlusive crisis is the #1 cause of admissions throughout the United States, period. It releases numerous inflammatory mediators, and sickle cell disease in general is not just the sickle cell. It has increased inflammation. Readmission rate is 1 week. It occurs in about 16% of discharged patients. In adults, 50% of patients are admitted within a month. And here is the 4 distinct phases of acute pain crisis. Usually it's a prodrome phase. Sorry. We have a steady state here for patients before they come in. They have the weather changes here. And then by the time they see you, they've usually used their pain medications at home. We ask them, have you finished your pain meds? So we always ask them that. And then here, established phase, they come into the hospital, get admitted, or they went to the ER, got discharged home. So about the average pain crisis in general, pre and post, is about 7 to 10 days. So when someone comes into the hospital, pain crisis, generally have been dealing with it for at least 24 to 40 hours. In the adults, we know the adults have been dealing with pain crisis for at least 4 to 5 days. The adults just deal with chronic pain in about 50% of cases in general. So the incidence of vaso-occlusive crisis, 6% of patients will start at 6 months of age. That's what we talked about the dactylitis. But generally by 8 years of age, 96% of patients will have their first pain crisis. So just to show you this is the evolution. As you get older, pain crisis develops. And even if you don't get it by 8 years of age, over time, they generally do develop it. Also, to mention splenic sequestration, rapid splenic trapping of cellular elements which causes precipitous fall in hemoglobin. It's usually associated with low platelets and low volume state. 30 to 50% recurrence rate. Most cases are mild to moderate with moderate worsening of anemia. Can cause hypovolemia, which results in hypotension. 20% of their blood volume can act as a sequester in the spleen, causing congestive heart failure in severe cases. Refer to sickle cell center emergency room immediately. So this is a case, 15-month-old patient, male with lethargy. So in these cases where they cannot speak, they're not eating, you can also, one of the things you do see commonly is a distended abdomen. They're just lethargic. You see pale palms and gums, rapid heart rate. The parents will say the heart rate is rapid. You generally see it in SS patient, but you also think it's in SC. And on exam, you hit enlarged umbilicus, usually at or below the umbilical cord line on the left side. You see low white count, low hemoglobin, and low platelets. Anytime you see a low platelet sickle cell patient, if they're not on hydroxyurea and they're under the age of 5, you think about splenic sequestration in those cases. Oops. There we go. Slides are, there you go. So, okay. And then stroke, another case I want to just mention, 7-year-old female, warning signs would be worse headache in her life, slurred speech, cannot move arms or legs. This is the past medical history. It doesn't matter what the past medical history is. But this is a life-threatening emergency. About 8 to 11% of patients with hemoglobin SS disease will have a neurologic event, stroke. Neurologic complications vary with age, maybe acute, chronic, or overt or silent, as you talked about. Overt strokes are one where you visibly can see a neurologic deficit on exam, cannot walk, talk. And the others, silent, the ones which are not necessarily emergencies, but associated with learning problems. 30% of patients will have these silent strokes. Warning signs, inability to talk, slurred speech, cannot move arms. So the medical definitions, hemiparesis, monoparesis, aphasia, dysphagia, seizures is a very common one. Severe headache, cranial nerve palsy, stupor, coma, and very severe ones, hemorrhagic stroke, which is rare. In pediatrics, it's more thrombotic strokes, which you have an evolution of blockage of blood supply, embolic, and in the brain, and that's how it happens. Hemorrhagic strokes are more rare in pediatric patients. And also can be an isolated event, or can also occur with acute chest syndrome or aplastic crisis, which you see with parvovirus V19. So if you have a patient with aplastic crisis, where that's when the parvovirus V19 virus that causes erythema infectiosum, this lap cheeks disease, where they have the red cheeks. Patients with aplastic crisis have a lower tick count. They can also, in very rare cases, present with a stroke. Stroke is a problem in sickle cell disease because it has 50% recurrence rate, so patients need to be started on chronic blood transfusions. Hydroxyurea, just as mentioned, has not been shown to have secondary prevention of stroke. They did a study called the TWITCH trial, not the Twitch, TW, a switch trial, SWITCH, and that showed that hydroxyurea is not effective in preventing secondary strokes in patients with sickle cell disease. So the only way you use hydroxyurea for prevention of stroke is primary prevention of stroke with elevated TCD velocities. So we talked about this already, cerebrovascular accident versus silent infarcts. With silent infarcts, it's important now. That was published in New England Journal of Medicine not too long ago, last year, showing that 30% of patients with silent 30% of patients with sickle cell disease have silent strokes, but they compare patients with silent strokes or cerebral infarcts on transfusions versus off transfusions, and they found that patients who were put on chronic blood transfusions who had silent infarcts had a statistically significant decrease in progression of their silent infarcts. So either the silent infarcts did not get bigger or did not develop more episodes of silent infarcts. So one of the recommendations which some of the hematologists are not all doing, some are, where when they're school-age children doing MRIs on the brains of sickle cell patients, SS or S-beta-0 patients, when they hit school age, they have silent infarcts, or if they have risk factors for silent infarct. They're having school difficulty, or they have very low hemoglobin. That's another risk factor for silent infarcts. Mention that. Stroke treatment, we do partial exchange transfusion or automated red blood cell transfusion to lower the sickle cell percent less than 30%. We usually do that with our blood bank and our transfusion medicine colleagues. Here's Dr. Joe Webb. Simple blood transfusion we usually do up front as an alternative to exchange transfusion for stable patients, but we usually don't try to transfuse above 10. So we do that as a temporizing measure until we do the exchange transfusion. The other warning sign we mentioned is acute chest syndrome. I think everyone knows about this. Fever, moderate chest pain, cough, arm pain, some shortness of breath. 70% of acute chest syndrome patients will present with a pain crisis, like in the arms or the leg or chest. Commonly, they can have any medical history. So it feels like, now the patients that I have taken care of, it's just like someone is stepping on my chest. If it's severe, that's a warning sign. Feel like I'm suffocating. Hurts to breathe. Pain crisis in my lower back, arms, but mostly lower back trunk area might be a sign that pain is actually acute chest in the lungs. Being extremely tired, not thinking clearly, that's the signs of severe hypoxia, locked oxygenation. They may not know they're actually, having severe oxygenation problems. Presence of new infiltrate, combination of fever or respiratory symptoms. Basically, is a definition of acute chest syndrome. Most common cause of death in sickle cell patients. 25% of mortality in sickle cell patients in the United States accounts for 5% of deaths among hospitalized adults after presentation. And just to mention, like, what are the presentation patterns? We know the acute chest syndrome in the younger kids usually have fever and cough, associated with viral illnesses. So a lot of the respiratory viruses can trigger acute chest syndrome. Very, very few of them will have pain. Whereas in the older adults and teens, will have more shortness of breath, but generally will also have pain crisis with it. And some people believe with the pain crisis, you can actually have a fat embolism. So one of the bone infarcts in your bones, in your arms, your legs, or anywhere can actually go to the lungs and cause a fat embolism, and that can also trigger acute chest syndrome in the older teens. Moving to therapies, I just want to briefly mention what we now thinking about sickle cell disease. Switch gears for the next 5 minutes to tell you hemolysis. So when we think about sickle cell disease, we think about hemolysis, we think about adhesion, we think about inflammation. We know that on the left side of the graph here, schematic graph here, you can see that you have hemolysis. Sickle cell red cell only lasts 20 to 30 days versus 90 to 120 days. That results in hemolysis. That also results in inflammation. White cells are activated. The endothelium, the endothelium lining is activated. You get platelet activation. You have inflammation and adhesion. So everything is involved here. So one of the things I want to mention is treatments. So we talked about hydroxyurea. New treatments is happening in DARI. DARI is L-glutamine, FDA-approved new treatment for sickle cell disease. The only thing I can report is previously published reports. We're waiting for the phase 3 study to be published very soon. But just want to mention that this was FDA approved a month ago from the FDA for children and adults with sickle cell disease. This is a drug, it's an amino acid that decreases the oxidant damage in general from any chronic inflammation. It's an anti-inflammatory, so decreases the oxidant radicals and inflammation that you see with any chronic illness, any chronic inflammatory process. So they use it. The study that I will present has been published already. They randomized trial patients 5 to 58 years of age who had 2 or more painful crises in the past 12 months. Patients with were assigned to randomly treat with DARI or placebo. The effective treatment was evaluated over 48 weeks. Patients treated in DARI experienced fewer hospitalizations. With IV or parenterally administered narcotics or ketorolac, which is Toradol, on average compared to patients who received placebo, 3 versus 4, fewer hospitalizations for pain crisis, 2 versus 3, fewer days in the hospital, 6.5 versus 11 days. Patients who received Indaari also had fewer occurrences of acute chest syndrome, 8.6% versus 23.1%. So that's FDA approved. The only thing I will tell you about Indaari is that Indaari, we did have a meeting with them recently, and that should be on the pharmacy shelves, I would say, by November of this year. They are working with the insurance companies, CMOs, Medicaid, Medicare to help get that approved. And then I wanted to show you, this is an anti-adhesion study, just showing you how complex sickle cell disease is. Just showing that this was a study, it was 300 plus patients enrolled, and this anti-adhesion molecule, polymyxer 188, did not work in decreasing pain crisis in sickle cell disease. So it's been difficult in finding drugs to really decrease pain crisis statistically significantly so that we can improve it for treatment. So this was the largest trial for sickle cell disease in the world in terms of treating sickle cell disease patients. It was anti-adhesion. It didn't work. And it was close, a p-value of 0.09, but it just did not work. Their primary endpoint was vaso-occlusive crisis. However, in this study, crizanlizumab, which is an was called P-selectin. It's an adhesion molecule on a vessel of the red blood cell. I mean, of the endothelial vessel. So this P-selectin adhesion molecule attaches white blood cells to red blood cells and white blood cells to the vessel wall. And what they've shown in previous research is that the white blood cell is involved in the evolution of pain crisis. They've studied this in transgenic sickle cell mice and also in red blood cell biology studies. And so basically in this study, crizanlizumab therapy resulted in significantly lower sickle cell-related pain crisis. And this was published in December of 2016 in the New England Journal of Medicine versus placebo. And just to show you, if you look at this Kaplan-Meier curves for median times for first to second sickle cell-related pain crisis, if you look at the placebo group, which is green, this is cumulative rate, and the low dose crizanlizumab versus the high dose crizanlizumab, that also decreased the dose, that decreased the evolution of or times to first and second related pain crisis according to the trial group. So this is also very exciting. There's another drug that's out there. I won't mention this phase 2/3 study that's coming out. Is Global Blood Therapeutics with GBT440. This plays a role in improving oxygenation to the red blood cells. That is coming out as another drug called by Prolonged Therapeutics that also uses the same mechanism. It causes the sickle cell, it releases oxygen sooner in the sickle red blood cell and causes less hemolysis, increased hemoglobin. So because GBT440 is a very exciting new drug that's coming out for sickle cell disease in phase 3 trial studies. We will be participating in that study. Also, bone marrow transplant. I'll end with this. Indications for transplant, a recent study, stroke, abnormal brain MRI, recurrent acute chest syndrome, lung disease, recurrent vaso-occlusive crises. This is a review for bone marrow transplant last year, and sickle cell nephropathy. These are common indications for bone marrow transplant. And we've done right now here at Children's National Medical Center over 50 bone marrow transplants, one of the largest bone marrow transplant centers in the country. And we have multiple trials for bone marrow transplant, conventional and unconventional, meaning a non-myeloablative transplant. We have sibling transplants, transplants from parents, called parental transplant, or haploidentical transplant, where the transplant is half-matched. So we have multiple transplant trials that are available here at Children's National Medical Center. So I think I'll end my talk and go from there. I'll stop for any questions from the community. Thank you. Any questions?